So, I think you all have participated in the first of the lectures, which is the eye exam. Today I'll be talking about the biology of macular degeneration, specifically age-related macular degeneration. And then next week we'll be talking about the treatment of macular degeneration. But I'm happy to answer any questions you might have this evening on any of the topics, whether it's talked about today or in future sessions. So we'll be learning about the what of macular degeneration, who gets macular degeneration, what are the symptoms. Many of you here will have recognized those symptoms. Go through the types of macular degeneration and what are risk factors, specifically modifiable risk factors. What can you do to protect yourselves, and non-modifiable risk factors. What risks do you have that has led you to have macular degeneration in the first place? And so this is part of the quiz, so pay close attention. This is the eye cut in half, and so light comes from the outside and first hits the cornea, and then it goes through the pupil, which is the black little circle that everyone sees when you look at each other's faces, and then it goes through your lens. And so if you've had cataract surgery, they put an artificial lens in the same location. If not, you have your natural lens. Light goes through that. It then goes through the vitreous, which is the gel in the eye, finally striking the retina. And then the macula and fovea are the center parts of the retina. And so macular degeneration is a degeneration of the central part of the retina, which is what you see with. Degeneration means that it's not functioning properly. And so the macula is just part of the retina. The retina is a big thin film that covers the whole back of the eye. And then the macula is the center part of that. And so what is age-related macular degeneration? Well, first it's related to age. So the longer you live, the greater chance there is that you will develop macular degeneration. And then it progresses over time in most cases. And so unfortunately, if you're 50, you have a little bit, let's say, and then over time, the longer you live, the more likely it is to advance. And then in a certain subgroup, it changes from the dry kind to the wet kind. And so many of the people who come to the office who are receiving injections, those are all people who have the wet kind of macular degeneration. And it turns out it's the most common cause of vision loss in adults over the age of 50. And so in North America, it's a huge, huge problem with an aging population. It becomes more and more common, and that's why when you come to the office, you'll see there's lots of other people with the same troubles as you have. And that's the same throughout North America and other parts of the world as well. Particularly as if you're of Northern European ancestry, that's probably the group of people who are most at risk.
So, is it like the dry comes before the wet, or can the wet comes?
So you can certainly have wet macular degeneration in which the dry was not recognized first. But it is felt that always you first develop the dry kind of macular degeneration for a time, and then over continued time, then it turns into the wet. But it is true that sometimes people present and they were never told they had dry macular degeneration, and all of a sudden they have bleeding at the back of the eye, in keeping with wet macular degeneration. And when you look back, if they had had an eye exam before, perhaps it hadn't been noted, perhaps it was subtle, perhaps it was just mild and they didn't really notice it. But we do believe that always prior to the development of wet macular degeneration, you have some dry, and then it transitions into the wet form over time. Yeah. And the longer you have the dry, the more likely it is to transition to the wet. Yeah.
My doctor was telling me that I had inclusions in the back of the eye, and this is just particles that are floating around back there. So I presume that's what the dry was about. Anyhow.
Yeah, so inclusions, what we call drusen. So these are age spots at the back of the eye, and they're deposits of material. There's the retina is a thin layer that sits above the retinal pigment epithelium. And most of the nutrition for the retina, or much of it, is supplied by these cells, the retinal pigment epithelium, and they have a variety of functions, but one of their jobs is garbage collectors. And so they collect garbage from the photoreceptors and then ship it out through your blood supply to your kidneys and then out. And they start to not work quite as well as they should over time. And so instead of shipping the material out as they should, it starts to pile up. and then they get behind farther and farther, and all of a sudden they have a big pile of material that's left behind, and these are called drusen. And that material then leads to dysfunction of the retina because it sits between the retinal pigment epithelium and the photoreceptors where they're trying to get nutrition. They're not working as well. And over time that leads to damage to the photoreceptors and then vision loss. And then in return the body tries to fix the problem by bringing in new blood vessels to bring in new nutrition, more oxygen. But the problem is these new blood vessels tend to break and they bleed. And then that's called wet macular degeneration. And so wet macular degeneration is actually a response to a dysfunction of the retina from the dry kind. And then in trying to fix it, they actually cause more harm than good, unfortunately. But it's the body trying to fix itself. So this is a picture of a healthy retina in a young person. And you can see the blood vessels. This is the disc where information travels from the eye to the brain. And then the macula, which is where your central vision is. And you can see it's kind of a darkly pigmented area, and there's no spots or anything like that. So this is normal. And so from a normal retina, as you become older, then things start to fall apart just a little bit, and then if you live long enough, it can fall apart still further. And so when you're 50, there's about a 2% risk of macular degeneration, but you can see by the time you're 75, the risk is 30, and if you are lucky enough to reach the age of 85 or 90, then the chances are higher still. And so almost everyone over the age of 90 would have some parts of macular degeneration. And so, it's wonderful you're able to live that long, but unfortunately the eyes do start to not work quite as well as they were when you were 20. And so our job as ophthalmologists is to try to protect your vision as long as possible, hopefully for your whole life. Now, unfortunately, risk factors include family, and so if you have a family history, you had been mentioning that your father and grandfather, and so if you have a family history, it means you have a genetic predisposition to macular degeneration. It doesn't necessarily mean you're going to have it, because your genetics are not the same as your parents, but they have similarities. So your risk is greater. And then if you happen to have pale skin and blue eyes, your risk, once again, is higher still. And so, in my family, my grandmother had macular degeneration, and so I'm at high risk over time of developing the same thing if I live long enough. And then if you have macular degeneration in one eye, then of course you're at increased risk in the other eye. And if you have the dry kind in, let's say, both eyes to begin with, and then you develop it in the wet kind in one eye, then depending on how long you live for, the risk of getting the wet in the other eye is also higher. And so these are all reasons why we follow people pretty closely. And if you've developed the problem in one eye, we're always checking both eyes because the other eye, unfortunately, is at risk. Now, the good news is with those injections, if we catch it early, we can preserve vision. We can stop it from getting worse in most cases. The key is early identification. So if we can catch it early. You had a question?
What is it if you catch it early? How do you notice?
How do you notice that there's early? Yeah. So we use technology as well as our examination techniques. And so what we're looking for is leakage at the back of the eye as well as bleeding. And that tells us that you have wet macular degeneration. And so you undergo a test called an optical coherence tomography exam. It's a laser scan of the retina. And what it does is it uses light to scan the retina and provide a very high resolution cross-section of the retina. And then we can look at it as if we'd taken a knife and cut your retina in half and look at it under a microscope. We don't have to cut you in half. We can just look at it using the light on the monitor. And it can identify very minute amounts of fluid. And so let's say you've been coming to the office on a monthly basis or every few months, and each time we look at both eyes with that scan, and then one time we don't see any problem, and the next time I see you, I notice that there's a bit of thickening. It's like a sponge, you put a sponge in the sink with some water and it'll swell up. The same thing happens to the retina. So all of a sudden the retina, instead of being thin and flat, is swollen like a sponge. And that swelling tells us that there's leakage. And then we have to figure out, well, why is the leakage there? Is it because this person has developed the wet kind of macular degeneration? And so that's probably the earliest sign that it's a bit swollen. And then if we attack it early with the injections when it's just starting to swell, we can stop any further swelling, we can stop vision deterioration, and we can preserve your vision. But It's not a perfect situation, of course, because it requires an injection into the eye. And so, nobody likes that.
So I noticed today and many weeks and months before, if I'm going outside in a windy condition, my eyes are running.
Yes.
Is this related to?
Yeah, so no, it's not related to dry or wet macular degeneration. That's the cornea, which is at the front of the eye, and that has to do with dry eye, which, we use both the words are dry, but dry eye has to do with the tear film. And so at the front of your eyes, you have tear glands that produce tears, you have oil glands that produce oil, and the combination of those two provide a stable tear film. And as you get older, that tear film is not as stable as it used to be, tends to be disrupted easily, and cold wind will disrupt it very easily, and all of a sudden, in response, your body will produce lots of tears. But it's a different process, not related. Yeah. Okay. So what are the symptoms? And many of you will have experienced these symptoms yourself. So early dry macular degeneration, there may be no symptoms because it's to one side of your central vision. Dry macular degeneration, as it progresses, you can get some blurring in your central vision. Colors, you had mentioned that colors change. Maybe they get a bit dimmer. They're not as bright and vivid, and maybe they look black and white. And then shapes become distorted with the wet kind of macular degeneration. Most commonly, although it can happen even with the dry, with deposits of drusen material, the retina is all of a sudden lifted up on little bumps, and that little elevation can cause some distortion. And then straight lines may appear wavy, and then a lot of people will notice a dark spot in their vision, often most commonly at night or first thing in the morning they'll notice it, and as the day progresses perhaps it fades a bit. That's pretty common.
Macular degeneration is a disease which affects the retina. In this video, we will describe the symptoms of macular degeneration. The retina is the layer at the back of the eye which helps us to see the world around us. Macular degeneration causes changes in central vision. Images which were once clear may appear blurred. Later, dark spots may appear and enlarge. Straight lines may become distorted or curved. Colors may appear less vivid or darker. The eyes work together. When one eye loses vision, it may not be noticed because the other eye is still able to see. Each eye must be tested on its own to identify changes in vision. The symptoms of macular degeneration may be found in other eye conditions. It is very important for an ophthalmologist to perform an examination to ensure that no other conditions are present.
So how do we identify it? You'd mentioned, how do we find wet macular degeneration early? One is with the OCT if you happen to be coming to the office, but we can use a test to test at home as well, and that's using the Amsler grid, and that's looking for early changes to straight lines. With the swelling of the retina, your mind perceives lines as not being straight anymore, and so with an Amsler grid, which is a grid you use with one eye then the other, you're able to pick up those changes pretty early. And so if you look at that on a daily or weekly basis, often you can pick up wet macular degeneration earlier, and then you can come in more quickly to treat it. Visual acuity is a test we do at the office all the time. It checks your vision, and often vision can be reduced as a result of wet macular degeneration or dry macular degeneration. The slit lamp is that microscope we put your chin in and look with lenses. That allows us a high resolution image of the back of the eye. OCT, or optical coherence tomography, that's the test you'll see the monitor in, and we look at the pictures one eye then the other, and we look over time. We look at this visit, and then we look at the previous visit to see if there's been any change. And then fluorescein angiogram, we don't do that as often as we used to, but sometimes people still get that. It's an injection into your arm, and then you're looking at the blood flow at the back of the eye to see if there's any leakage. Abnormal new blood vessels tend to leak, and normal blood vessels shouldn't. And so it's a way to catch those early blood vessels if they're starting to leak.
I've got one question for an earlier
Sure.
slide. Sometimes when I see a car go past, the front part of it seems elongated. Am I imagining this, or is this?
No, that's to do with your macular degeneration for sure. Yeah, and so that's to do with distortion.
Yes?
And so it's not uncommon for people to notice that shapes, instead of, let's say you look at a square, the square is no longer square, it's a rectangle. And that's because the photoreceptors, which is what you see with, have been displaced because of swelling or fluid or some raising of the retina. And so the retina should be flat, and when it's not flat, if it's lying over a bump of any kind, then shapes will appear distorted. And so that's a very common problem. Yeah. So this is an example of an Amsler grid, a normal Amsler grid where lines are straight versus distorted because of disruption of the retina. And so this disruption is specifically as a result of the retina not being flat anymore. It's raised and lifted up because of fluid or bleeding. So phantom vision, what's called the Charles Bonnet phenomenon, is not an uncommon experience for many people with macular degeneration. Your brain is always trying to fill in missing areas, and so if you're missing part of your vision because of bleeding or thinning of the retina or leakage, the brain tries to fill in those missing areas with patterns or shapes or figures or people or flowers. And so you'll be doing whatever, and all of a sudden you'll notice something that's not there, and you'll realize, hey, this is not possible, it's not there, and yet you see it. And they can be beautiful patterns, but people don't usually talk about it because they're worried something, it's not making sense. But this is a very common problem, and so if you notice that yourself, that you're just one of the many people who have noticed that. And it just tries to fill in the blanks, and over time this usually fades. And so it happens for a few months and then will fade and go away. So what are the challenges? Many of you will have experienced this in terms of activities which require fine central vision are impacted. Reading, recognizing faces, driving, anything that requires fine detail can be lost because of macular degeneration, and depth perception as well. If you have wet macular degeneration in one eye and dry in the other, then all of a sudden your depth perception can be off significantly with a reduction in vision. It can make it more difficult to do things, activities of daily living. And so there are ways to overcome this in terms of with specific training. I think of the CNIB providing training for this sort of problem. And also tools, a variety of magnifiers, better lights, better contrast sensitivity, that sort of stuff can help you to overcome some of these areas. But unfortunately not make it back to normal. So we talked about types of macular degeneration and how the dry macular degeneration is what starts in almost all cases. And then from there, a subgroup of people go on to develop this wet macular degeneration, and those are the people we often see here at the office because we're treating them with injections. And it works out to be about 10% of the population who has dry macular degeneration will go on to develop the wet kind of macular degeneration on average. And so this is a picture of dry macular degeneration in the corner. You can see those little yellow spots in the corner. Those are drusen or age spots, material left behind. And the dry is the 90% of the cases. 10% are the wet kind. And these are the people we're really hoping to catch. Is that if we can catch the wet kind very early and we treat it very early, then we can preserve vision. Of the two kinds, the dry kind is actually the better kind to have because it's much slower. It doesn't usually change as quickly. So that's just the enlarged picture of a patient with dry macular degeneration. You can see all those yellow spots. And so all of these yellow spots are material left behind underneath the retina called drusen, and that's the hallmark of dry macular degeneration.
Dry macular degeneration affects the health of the retina. The retina is the lining of the eye which responds to light. Here, a cross-section of the retina can be seen. In the dry form of macular degeneration, metabolic end products collect underneath the retina. These deposits are called drusen. Over time, dry macular degeneration can lead to scarring or thinning of the retina above. Dry macular degeneration may cause gradual central vision loss over time. Every patient has a different course, and some patients preserve vision for a very long time. Your ophthalmologist will monitor your eyes. Ask about how stopping smoking or vitamin formulations can help to slow the progression of dry macular degeneration.
So of the cases of people who have dry macular degeneration, 10% will go on to develop wet macular degeneration where there's bleeding or leakage. And the vision can quickly change without treatment. And so This is why we try to catch this as quickly as possible, because with our treatments we're able to preserve the vision and in some cases improve it. But it's much easier to preserve the vision than to improve it. So if we catch it early, then we can prevent, hopefully, vision loss. So this is an individual who's gone on from the dry to the wet. And you can see that in the center part of the retina, in the macula, there's some bleeding underneath the retina. So this person has wet macular degeneration, and the blood vessels have broken and bled underneath, and so as a result the vision is down.
Wet macular degeneration may develop in patients with the dry form of macular degeneration. In the wet form, blood vessels that are leaky and abnormal begin to grow into the retina. Unlike normal blood vessels in the rest of the body, those seen in wet macular degeneration cause swelling or bleeding into the retina. Wet macular degeneration may cause either sudden or gradual loss of vision as these vessels leak fluid or bleed. If untreated, vision loss can progress.
So in summary, there's two types of macular degeneration, the dry kind and the wet kind. And the dry kind is either deposits of material, or over time sometimes the retina can become thinned and also doesn't work properly. And then the wet kind is when there's new blood vessel growth and either there's bleeding or fluid leakage.
I was just wondering one thing, when you're talking about these drusions,
Yeah.
is there a possibility that they can be removed, or?
Sure, and so that's an interesting question, and in fact research had tried to remove drusen with laser, and so they were actually successful at removing drusen with laser, but the function did not improve, and it didn't reduce the risk of transformation from dry to the wet. And so although they got rid of the material with laser, it didn't make any difference. That being said, people continue to try to modify the risk of progression with a variety of different techniques. And there's a new laser called a femto laser, which is a super fast laser, which is currently being investigated for that same purpose, in terms of trying to get rid of drusen without damaging the retina, thereby improving function. Because I talked about how it blocks nutrients and stuff from going back and forth. Well, if you get rid of it, maybe those nutrients could get through more easily. The body in response would not bring in blood vessels. It wouldn't have to, because the nutrients were getting to where they should be. And so that's the hope. But so far, nobody's been successful at doing it properly and helping improve people. Yeah, but a lot of money and a lot of research is going into that specific question. Yeah. So what are modifiable risk factors? So the big one is smoking. Smoking is less common now, but many people have smoked or smoke now. And so smoking is a big risk factor. It increases your risk of progression from dry to wet by just between 3 and 6 times. And so if you're able to quit, that's a really important thing, hard to do. And if you've smoked in the past, unfortunately your risk is greater. Alcohol, a drink a night probably wouldn't cause any problems, but overuse of alcohol can certainly cause problems. High blood pressure. You think about these blood vessels in the back of the eye, anything that could increase the risk of bleeding could increase the risk of vision loss. And so high blood pressure is a problem. Obesity, too much fat in your diet, all of these increase your risk of wet macular degeneration. And then UV light exposure. Now, UV light exposure is important, but it's nowhere near as important as stopping smoking. If we could do all the things we could do, if you could just get people to quit smoking, we could really do a big change in terms of risk of progression to wet macular degeneration.
Yeah, I smoked for about 20 years.
Yeah.
That was over 25 years ago when I quit.
Yeah, so good for you. Yeah, so you've done yourself a great service by quitting. Yeah, there's a question in the back there.
Just about the same as his. I quit 25 years ago.
Yeah, and so we'll talk about it. What's interesting is that vitamins, so we're going to talk about that in a minute, but there's certain vitamins that are good for protecting your eyes. So vitamin C, zinc, copper, vitamin E, and then lutein is a good one. We used to think that beta-carotene was also important, so in carrots and things like that. But most recently, just in the last few months, a study came out looking specifically at that question. Does beta-carotene reduce your risk of progression? And it turns out that lutein, which is a different kind of antioxidant, works just as well as beta-carotene. And the trouble is that beta-carotene increases the risk of lung cancer for smokers. Whether you're smoking now or have ever smoked in the past, your risk of lung cancer is slightly increased if you take beta-carotene supplements. And so people who are ex-smokers or current smokers are recommended they do not take vitamin A supplementation. So if you take it in your diet, that's okay, but if you're taking supplements, that's considered dangerous. Anyway, so as a result, nowadays we don't actually recommend beta-carotene as part of the program to reduce the risk of progression, and instead replace it with lutein. And so on vitamins, if you're thinking about vitamin supplementation, Vitalux is a pretty common one. Vitalux S for smokers actually is the one to take for everyone. If you're an ex-smoker or if you're a current smoker or pretty much anyone now, the Vitalux S or other brands which do not have beta-carotene is the stuff to take, for sure. And you can ask your doctor about that too.
The other kind of vitamin, Vitalux, without any letters, it's the same quality, same good, same benefit?
So it doesn't say arids?
No, I just bought from Costco.
Yeah.
Vitalux, they had green color.
Yeah, so there's a Vitalux which is for healthy eyes.
Oh,
And so you shouldn't be taking that one if you have macular degeneration. That's similar stuff but less concentration.
so I have to use an S.
You have to, yeah. If you're buying Vitalux, it needs to be the one with the S.
Okay.
That's the one to take.
Yeah.
And it's not the end of the world if you have it. You've bought the other kind, you can finish it. But once you've finished it, you should buy the one with the S.
Yes.
That's the best one to take.
And so the S is preferable to plus?
Yes. Well, so that's the other question. So omega-3 was looked at, and so in the last year or two, I used to recommend people take omega-3. And there's actually a lot of good reasons to take omega-3 outside of the eye, in terms of from a cardiovascular risk factor for heart attacks. Omega-3 is good, and it's also good for dry eyes. So if you're having problems with tearing in the winter, omega-3 is good. But for macular degeneration, it turns out it doesn't make much difference. And so they looked at a head-to-head comparison, people who were on omega-3 versus not on omega-3 who had macular degeneration, and it didn't make any difference over 5 years to progression, to getting worse.
That's what my pharmacist was telling me.
Yeah.
I was insisting on omega-3.
Well, so unfortunately, the data has only come out recently. So we're always trying to do what's best and providing advice as to whatever information we have. But the newest data suggests that omega-3 doesn't make much difference. So I take omega-3 for other reasons, but you don't need to take it for your eyes.
Vitalux is omega-3, isn't it?
Well, you can get Vitalux with omega-3 or without. So if it's with the omega-3, you take 4 pills a day. It's a bit more expensive, but it turns out you don't really need the omega-3 component. Yeah.
So how many tablets are you using Vitalux S?
2 tablets is the appropriate
At
dosage.
once, or
You could take them at once or separately, whatever is most convenient. Yeah, question?
Well, I can't resist saying to these two gentlemen that I stopped smoking 40 years ago. And I'm setting a good example for my 4-year-old.
Good for you. Well, it's funny because back in the day, of course, doctors were big proponents of smoking. And I remember I went to McGill in Montreal, and the way we raised, back in the day, the way they raised money for the gym was by selling cigarettes, McGill cigarettes. So we've learned a lot over the years.
I have one more question about the Vitalux. So for someone like me who doesn't have signs of it yet, I would be on the regular
Yeah, so
healthy eyes.
that's a very good question. So what do you take if you don't have macular degeneration, but you have a family history, and as you're getting older, you're worried you're going to develop it yourself? And so you could take healthy eyes, but the reality is a healthy diet. Lutein probably would be a reasonable thing to take because there doesn't seem to be any downside to taking lutein. It's a high concentrate antioxidant. I wouldn't take high dose vitamin E because high dose vitamin E can actually increase your risk of stroke.
Okay.
Turns out. So if you have a specific reason to take it, great. Vitamin C would be reasonable, and zinc would also be very reasonable.
And there's pills that are just lutein, like
Yeah,
20
and so
milligrams.
yeah, and so In the studies, 10 milligrams was used, but if you wanted to take more, we don't think there's a downside to taking more. The big thing is you don't want to be spending too much money, and so if you can get a no-name brand, that'd certainly be the way to go. Much cheaper and work just as well.
And if you're taking Vitalux S, is there any benefit to adding in a lutein pill?
Well, so there's lutein in Vitalux S, and it's 10 milligrams. So you probably don't need to take extra. Yeah.
Thank you.
Yeah, no problem. So what can we do? So stopping smoking, 40 years ago is great, 25 years ago is great. If you're still smoking, try to quit. That makes a big difference even today. And healthy diet, so lots of leafy green vegetables, perhaps less meat, less fats, more orange vegetables, yellow vegetables. Exercise, it turns out that if you compare head-to-head people who exercise on a regular basis, let's say daily exercise versus no exercise, those people who are exercising have a better chance of not progressing for macular degeneration. And then UV protection. UV protection is important, but it's not the end of the world if you're not doing it all the time in terms of the risk increases slightly, but nowhere near in the same ballpark as the smoking business. Smoking is probably the greatest modifiable risk factor that you can do.
When you say protection, you mean sunglasses?
Sunglasses, yeah, sunglasses.
And
With
is there-
UV protection.
Okay.
Okay, so in summary, what is macular degeneration? Who gets it? What are the symptoms? What types of macular degeneration? We talked about the dry and the wet. The non-modifiable risk factors, age, genetics, modifiable risk factors, smoking being the big one, but also diet, exercise, sun exposure,